I joined Beth Israel Deaconess in January of '08 from outside of healthcare, and in the last 6.5 years have really experienced the transition of going from an academic medical center to an academic medical center that is the hub of a regional network of healthcare providers. So let me give you a couple of examples. The first is about patients. I think on the day I started, there was not a single patient in the hospital that was covered by some sort of risk management insurance contract. Probably last week, more than 2/3 of the patients in the hospital were covered under such contracts. When I started, we owned one community hospital. We now own 3. We have affiliations with 5 more. We have a regional network of 2,700 physicians, more than 500 of which are primary care physicians. And that number of physicians is up by 60% over the last year. And the third indicator has to do with the location of my projects. My largest projects are not on the main campus. My largest projects that I've completed this year, the largest one is an outpatient cancer center located on the campus of one of our community hospitals. And the second largest one is in a medical office building about 5 miles from the main campus that has primary care, medical specialties, and something called an urgent care center that is plunked in the middle of 2 emergency rooms, one at the main campus and one at our community hospitals. So I've, in my 6.5 years, watched the speed and dynamics of healthcare affect one little institution.
Kip, I'll let you go ahead.
Oh, good evening. My name is Kip Edwards. I'm Vice President for Development and Construction and Corporate Facilities for Banner Health. I looked today to see how long I've been doing this, and I was kind of shocked to realize 35 years. And I checked the math twice because I thought there was something wrong with it, but I go back about 35 years with health facilities, about 70 million square feet of facilities, 8 billion in projects in different organizations. At Banner, we do about, we tend to keep about 1.5 billion active in projects at any given time, about 250 projects. And so our projects tend to be a little smaller these days, but more of them, which is keeping us particularly busy. I came to Banner by way of California Pacific Medical Center, which is part of the Sutter Health System, 4 hospitals in San Francisco. Prior to that, a number of years with Kaiser Permanente, where I was responsible for a wide range of the national shared services, one of which was National Facility Services, and then some time at the University of Michigan, which is why I have the amazing blue on tonight, since we finally won a game yesterday. That's been fun. A little bit about Banner Health. We're a not-for-profit. We're located in 7 states. We have about 25 major facilities, and that number is increasing daily, literally, as we go. But also about 120 clinical locations. If you count up all of the outpatient clinics, health centers, ambulatory surgery centers, and that number is greatly increasing. We employ almost 1,000 physicians now. That number is growing rapidly day in and day out, so some of the similar changes that you had mentioned before. When we look at our vision, we basically say we're focused on clinical excellence, innovation, and the coordinated patient experience, and putting those 3 together going forward. Recently, we did creating a major vision here for Banner Health going forward. And our leadership team was asked to peg us on a number of scales. And they picked us based on 3 points. I won't go through the whole scales, but the first one was that we'll be focused on community health, population health management. So the health and managing the health of large populations. The second that we expect to be the bulk of our business will be in a risk-based contracts or capitated type agreements over time. We would like to have almost all of our business there. And third, it will be a highly integrated delivery system. So we chose where we're heading on that scale. Now we're working very actively to get there. Jeff?
My name is Jeff Land. I serve as Vice President of Corporate Real Estate for Dignity Health. Dignity Health is an integrated and diversified healthcare system that has about 40 hospital campuses in California, Arizona, and Nevada, and about 300 clinics, and then another 175 PTOT operations throughout 30 states, including some diversification of late. And I highlight this to what Kip was just saying about how our business is changing a little bit. 5 years ago, I would have said that our acute care business was probably easily 75+% of our gross revenue. Today, less than half of our total revenue comes from acute care and is reducing month over month. We are becoming diversified out of the direction of healthcare, out of the direction the ACA is taking all of us. And so it's an exciting time, particularly for, not just for being in healthcare systems, but being on the real estate, design and construction, mergers and acquisitions, facilities of every kind, and the sorts of things that all of us in the room deal with every day. This is a changing world, and change management is probably needs to be on our business cards going forward.
Clay?
Thank you. Clay Ashdown, Intermountain Healthcare. The overall strategies that I think we're employing and certainly pursuing are not dissimilar from what's been discussed here. For those of you not familiar with Intermountain Healthcare, primarily based in Utah and southeast Idaho, we have 21 hospitals, a little over 150 clinics. We employ about 1,200 physicians and have about 700,000 insured lives. Like what's been said previously, certainly extremely focused on not only leveraging our health plan, but also looking at our highly aligned payers and looking at ways that we can be proactive with the way that we manage the population, so that we are looking at ways to drive out unnecessary utilization, attempting to be more thoughtful about not just being a network that treats the sick, but also is highly active in keeping people well. As a matter of fact, we just barely, as of about a month ago, actually changed our mission statement to be more comprehensive in how we look at things, and not strictly focused on health care, but also the wellness and overall well-being of our population.
Well, thank you all. I know I'm trying to make sure that I don't keep my back to most of a lot of the room here, so well, I'm trying to turn a little bit so we can talk to all of you. I was hoping to wear my KC Royals hat tonight, so Kip, you have on your blue, but I really was going to be wearing blue tonight, and it didn't work out for me. So Clay, one of the things that we talked about, and we had a little bit of time to talk ahead of this, is what do you think that healthcare is going to look like in 5 to 10 years?
Certainly I'll offer my thoughts. I think the one thing that we can all safely say for sure is that it's not going to look like it does today. Now, a lot of people assume that all the changes are predicated on the Affordable Care Act and the consequences. And a lot of the issues that are driving us towards these changes were sort of germinating long before the Affordable Care Act ever was signed into law. Ultimately, as everybody knows, healthcare here in the United States was on an unsustainable trajectory in terms of cost. People for years have been looking at ways to drive out cost. But I think, in a more meaningful way, really what people are now focusing on is really, and Brent James, who is our Chief Quality Officer and is kind of a forward thinker in this area and has been for decades, is our, I would say, our compass, so to speak, in terms of how we're looking at the future, and really saying how can we do the right thing for our population, which in fact will help drive down those costs, and clearly looking at things like utilization management, wellness, chronic care management, personalized primary care, those sorts of things that are not just looking at you know, I think everybody's been so focused on cost control for so long, which is prudent and necessary, but it's been on a cost per case basis rather than on a whether it's an intra-case basis or population basis. And really, the fact of the matter is that we're, you know, the way that we've provided care, certainly the way that we've compensated care, is not consistent with where we need to get to. And so I think greater focus on the continuum of care, whether it's home health, telemedicine, those sorts of things, there's going to be, you know, as Jeff indicated, much less reliance on acute care and more reliance on the continuum of care, and keep making people also accountable for their own care and having some accountability for their own cost management.
So I'm hearing you say that there's a lot of changes going on now. Do you see a time when you're going to get there and you're going to be at that place because you're saying, okay, in 5 to 10 years we're going to look different? Is there a goal? Do you believe it's going to be 5 years, 10 years?
That's a great question. Our organizational goal, and we've been fairly public about this, and it's kind of being driven out of our health plan, but I think it permeates throughout our entire organization. But it's basically to get to a place where the cost of healthcare to our health plan members, and would also be extended out to those that we contract with, but that their cost of premiums and out-of-pocket costs would not grow at a rate higher than general inflation. And clearly, anybody that's looked at the past 2 decades of healthcare costs, you know, where it's been 2x, 3x, clearly that can't continue. And so that's our internal goal, and everything in terms of our long-range planning and everything is geared around that fundamental goal. Do I think we'll ever get to a point where everybody is satisfied? Clearly not. But I do think, hopefully, I mean, ultimately, if we don't get to a place that is sustainable and tenable from a global economic perspective, then we can't continue to function. It's basically a situation where we need to get there.
So Kip, we were talking earlier, and you said that you do have there's always strategies for employing and saving costs, and that never stops. I think Jeff had said that too, is that those changes never stop, and we're always doing initiatives. We always have things going on to reduce costs. But I think a better question for you, Kip, is what actions and strategies is your organization employing to prepare for the future and what's coming in the future?
Well, I think we're doing a number of things right now, and a great deal of our activity right now is really focused on the future. In fact, a lot of us feel a little schizophrenic because we're having to function today, so part of our effort's going there. It's a full-time job. Then we have this other full-time job, which is prepare for the future. The biggest thing we're doing is building capabilities. So from a facility standpoint, we are building and deploying facilities into the communities. We're building multi-specialty health centers and pushing them out to where the service needs to be delivered. Those are just buildings. That's the easy part. We can do those day and night, forever and ever. Nothing much will change. Along with that, the hard part is we're hiring physicians. A big focus on primary care physicians to be the lead in the healthcare delivery in those facilities. But again, that's not enough by itself, because all we'll have then is a collection of physicians doing roughly what they used to do before, and that won't get us to the quality or the cost structure they want or the service structure. So beyond that, we are building a number of member service capabilities. If we're really going to get into risk-based contracts, you have to have the member service capabilities. The worst thing we could do is jump in big and not be able to serve members that we're signing up. Simple things, can't get cards to them. Can't get them signed up for doctors. Those are the things that will infuriate people. They'll leave quickly. But then beyond that, we've got to be able to offer the online access, the phone call or the call centers, all those things that people really want that A, give them quick and easy access, and B, really make care readily and easily available to them so they'll seek it right away when they need it. And that's the lowest cost care. Then the third big area is building programs around quality, where our physicians, we have big groups of physicians working actively, looking at the development of the best care paths for every situation that can be shared across the medical group, and we can deliver care consistently and at the highest quality possible. So all those are going on at once right now. And then we do our day job in the spare time.
So one of the things that I've had discussions with a number of individuals in the industry lately, and Walter, I'm going to direct this to you, it's probably the first time in the history of healthcare facilities where there's been a culture that healthcare facilities can internally take care of everything, and we want to own this, and we've got people that can do this and this and this, and by golly, I'm not going to outsource that because I've got a chiller technician that can do that. So what skills are you seeing are going to be needed in-house versus being specialized or being externally outsourced in the future?
Well, I think a big emphasis is integrating the clinical planning with the facilities planning. So I think that we need much stronger skills in strategic planning within our facilities group, because it is to be part of that strategy. Where do our facilities need to be to serve our patients? Where are our physicians? Where are the best locations? So I think we need almost more skills in real estate feasibility in terms of location, in terms of feasibility of looking at individual projects. And do they make sense? Does it make sense to put up a medical office building in X location or Y location? I think we also need greater skills in terms of due diligence reviews, which now that we're going out and looking at different facilities that we're about to acquire and own, how do you have a team that hits the ground running and can quickly evaluate every dimension of an asset that you may be trying to acquire? That is one that I think there's a good need for outsourcing, to be able to put together that team, hit the ground quickly, and not take away from those same resources that are doing the day job. So I think there's a lot in terms of that kind of planning and real estate analysis. And I think for an organization like mine, there's more, instead of worrying about the management of a single facility, it's about worrying about the management of multiple facilities. So then you're talking about setting standards across the network, you're talking about monitoring those standards, and you're talking about more capability in each of these organizations. I mean, Renee is of course interested in outsourcing. I see that in, I guess, stretching project management skills. I have a team that is incredibly efficient on my main campus. You can't believe the number of projects that my staff can handle as they walk from floor to floor and building to building. But when I have to cite 2 individuals at a project 10 miles away from the campus and they need to be there full time, then I have to face the decision of, should my staff grow, or do I need to find stronger project management capability that I can rely on? I bring a bias coming from outside of healthcare. I don't want to offend architects in the audience, but I'm sure I will. I come out of a tradition where engineers are the lead in designing projects, and if they don't win the design, they'd love to be the owner's rep. And so there's a ready stable of people who you could rely on to manage a remote construction project. I think the engineering, the architectural community has not developed that particular interest. So that kind of field, in my mind, has a gap. Some real estate firms try to fill that gap, but I don't see a strong stable of owners' reps that I would feel comfortable, which makes me rely more on growing my in-house staff.
So I need to resurrect my old business, that's what I did for a living for a number of years. So very interesting take on that. And I know that I've seen more positions created recently for directors of real estate for healthcare organizations. That really kind of went away for a while with a lot of healthcare organizations. Now all of a sudden we're seeing this trend where that position for real estate management is back.
One of the first efforts that we did in consolidating our network was actually to try to consolidate the management of all the properties owned by all the facilities, because obviously there's money to be saved in looking at those properties from a consolidated view.
I think that's coming with this trend to push delivery into the community. To do that, we're acquiring sites, leasing sites, building buildings scattered around the communities we serve, way more than building things on top of our medical centers that have been sitting there. So our real estate activity has gone through the roof in the last couple of years.
Well, Jeff, with that being your title, you're Vice President of Corporate Real Estate. So maybe you could speak a little bit to what changes you're seeing, and you're in that real estate arena, and we know that we're going out to populate, basically going temples to tents, or however you want to put that, but we're putting the services out into the communities, and you've got to be incredibly busy right now. What is your take on some of the things you're seeing, some of the trends? How are you managing that real estate activity? And this wasn't on the list, by the way, so I'm
Which one
trying
of the
to stump
questions do you
him.
want to start with? No, I think it's interesting and a little disconcerting for me that right now we're sitting on a panel. The title says innovation, and we're talking about doing things better than we've done them before. And I think we need to start talking about the things that we have never done before. And when you think about innovation in the delivery of healthcare, we really need to stop talking about medical office buildings and clinics. We need to talk about what is the disruptive pattern of healthcare that will skip the MOB and go to the home. How are we going to expand the use of telemedicine? Google Glass, we're testing Google Glass as a clinical aid for primary care providers to speed reviews and to speed care at the bedside. We're talking about shared clarity, a joint venture we recently started, I guess about 2 years ago now, that really the first reality that was predicted came true about 2 weeks ago in Massachusetts, I believe, where now, well, I think this is right, where now you can go online, you can get your doctor's information, the cost, you can, for the first time, actually compare like services, at least on a limited basis, and you can expand on this. Clearly, it's in your backyard, but I think that's wildfire. That is not Massachusetts specific. Within, I think we'll measure it in months and weeks, where across the country you will compare the cost of the services you're getting in healthcare the same way you compare buying broccoli at the grocery store. You will be able to do this. And when you start being able to do that in America more than anywhere else in the world, we are very consumer oriented, and we will look at that. It will drive behavior. If there's a wild card in the next 5 to 10 years, it's what will the public do with the information they have? What will they do when they start making their own decisions about health care? And yes, cost will be something, yes, quality will be something, but what else? And I think we're going to find out that the patient experience, the family's experience, and our staff and physician experience will begin to mold and move on a branded basis the behavior of our populations as we move to population management. So, I mean, I could go on all day about that, but so you just got a little piece of it. But I truly believe that branding healthcare in the future and branding the experience as we open up the markets means we will do things we have never done before. We will do them differently, and it will not revolve around as much bricks and mortar, not even just the temples to tents, but I'll use another one. As you move from volume to value, go to the payer side, and the dollars that are going to drive our business. When you move from a volume-based payer mix to a value-based payer mix, we're going to do less of it, and we're going to do it lower acuities, yes, but probably skipping over building thousands and thousands more clinics which believe me, I'm getting tired building right now because everybody's doing it. We're all doing it. But this is an interim move. We are getting out of that. We've got to go to where people care for themselves, and a little bit to what Clay was talking about. They take care of themselves, they make their own choices, and we can care for them remotely.
So Clay, I'm going to bring it back to you a little bit. And these gentlemen all submitted some of these questions, and I'm going off of these a little bit and kind of taking it a little different direction. One of the things that you had mentioned was how information technology is going to really play a huge part in how it's going to impact care delivery and what some of the implications are for facilities planning when we really truly pull information technology in to drive the patient care model. So do you want to speak a little bit on that?
Yeah, I'd be happy to. And I was just thinking as Jeff was speaking here about the nature of innovation and the difference between incremental innovation and disruptive innovation. Actually, so Clayton Christensen, who I'm sure many of you have heard of, renowned author and professor at HBS, he actually sits on our board and has been quite vocal in challenging us to think about innovation differently rather than just finding ways to do things more efficiently than we've done them before, but really look at things differently. And as it relates to technology, clearly, we're at this crossroads where we're trying to be thoughtful about, as we design these facilities and trying to be thinking about how will these facilities be used. To quote, it's an overused quote, so I apologize, but Winston Churchill basically said, first, and I'm going to get this wrong, but we form our buildings, and thereafter they form us. Something along that line. I'm sure I slaughtered it, but really the way that we utilize technology, whether it's telehealth, whether it's communicating, having centers of excellence and being able to have intensivists monitoring intensive care patients in various facilities, whether it's having e-visits, those sorts of things, how that impacts the way we build our buildings, I think has a profound influence. And so being thoughtful and building in that flexibility so that we're not basically on day one building this antiquated facility that's really not set up for the way care is going to be delivered 15, 20 years from now. It puts, I think, the onus on, as we look at partners and people that we work with and thinking through how we're going to be delivering care, I think it really helps us to challenge ourselves to say, look, we're not just thinking 2 or 3 years down the road, we're really thinking 20 to 30 years down the road. And it's a tremendous challenge, but it's an exciting time, I think.